and we'll start with alcoholic hepatitis. So as the name suggests, alcoholic liver disease in general is where consumption of alcohol damages your hepatocytes. This damage is most commonly affecting our zone 3 or centrilobular zone of the liver. This should make sense for a couple different reasons. In the anatomy section, when we talked about our liver lobules and zones, I showed you this somewhat complicated slide. What I want you to realize here is that the zone 3, the centrilobular zone, has the highest concentration of P450 enzymes and the highest mitochondrial content. And so if we start with the P450 enzymes, the problem with alcohol is that it can damage those P450 enzymes directly. And once it interacts with those P450 enzymes, it'll create reactive oxidative species that can damage that specific zone initially. And keep in mind, the damage isn't just confined to zone 3 of the liver. I just want to point out that if they tell you where would the damage be most severe, and they've listed all 3 zones of the liver, they probably want you to pick zone 3 or the centrilobular zone. Additionally, this zone 3 has the highest mitochondrial content. And as we know, alcohol is a mitochondrial toxin as well. So if alcohol comes into this region, it can damage that mitochondria, and fat accumulation generally begins in this zone first. So I've put this slide up to discuss the alcohol liver diseases more broadly. So you can get alcoholic fatty liver disease. You can also have something called alcoholic hepatitis. And finally, if the damage is severe enough and irreversible, you'll end up having alcoholic cirrhosis. So I'll just talk about the differences between each of these really quick. So alcoholic fatty liver disease, as we just saw in the liver lobule, I mentioned that the mitochondria can get damaged and fat deposition usually begins in zone 3 of the liver. So how does that fat deposition even occur in the setting of alcohol use? So alcoholic fatty liver disease can also be referred to as hepatic steatosis. And the pathogenesis here is that metabolizing all that alcohol is going to increase your NADH to NAD plus ratio. So you're going to get a higher ratio of NADH than anything. And what's going to happen is when you have all this NADH, it's going to change your reaction mechanism to where you're going to get increased fatty acid synthesis and decreased fatty acid breakdown or oxidation. So let's draw this in a diagram to make so it makes more sense. So if we have alcohol or ethanol, what's going to happen is ethanol is degraded to a compound called acetaldehyde, and that's further degraded into acetate. And that's how we metabolize alcohol in our system. And there's 2 enzymes we need to know in this pathway. The first enzyme that degrades ethanol to acetaldehyde is called alcohol dehydrogenase. And the second enzyme that degrades acetaldehyde to acetate is acetaldehyde dehydrogenase. While we're looking at this basic reaction mechanism, I'll just go over a few things they like to test. This isn't necessarily GI related, it's more toxins and other pharmacology, but while we're here, it's good to keep this in mind. Some people will ingest methanol or ethylene glycol. Usually it's in 2 settings. One is an attempted suicide, and then the other is somebody who has alcohol use disorder and they don't have any alcohol in hand. So they might try this instead because some of these have a sweet flavor. And then a third, actually, now that I think about it, a third cause of methanol or ethylene glycol intake is if a child accidentally gets into somebody's like shed and ingests this. So if either methanol or ethylene glycol are ingested, what's going to happen is that this methanol or ethylene glycol will use that same alcohol dehydrogenase enzyme to form a toxic metabolite. So it's actually safer for the body to keep it in the methanol form or the ethylene glycol form rather than allow it to form this toxic metabolite. So you actually treat this in one of 2 ways. You can, usually what they'll do which you can give them ethanol technically. This is kind of a little bit frowned upon, but you can give ethanol because what that'll do is that'll force the alcohol dehydrogenase to uh, use all of its resources to convert ethanol to acetaldehyde. And in that process, methanol and ethylene glycol would be unable to use that same enzyme to form the toxic metabolite. What's more common, and you're probably going to see this on tests if they give you a question like this, is they'll want you to pick fomepizole, which is an alcohol dehydrogenase inhibitor. And in this way, you're going to keep it in the non-toxic form. And just as a heads up here, something that I always thought when I was studying for this, I thought, what would happen though after your uh, after your fomepizole has basically completed its course, are you still going to have the same problem where you have methanol and ethylene glycol sitting in your system, and then it's just going to cause a delayed reaction? Well, what actually happens is that if you inhibit enough of these enzymes, there's still some ethylene glycol and methanol getting converted to their toxic metabolites, but it's nowhere near the same levels that cause a really, really bad reaction. So you're almost slowly tapering it out of your system using this medication. While we're looking at this diagram, I just wanted to talk about one more thing, which is disulfiram. So disulfiram can be used in alcohol use disorder. It's not really used as often nowadays because the person who has the disorder can just not take the disulfiram, and then they can still, it doesn't reduce the cravings in any way. And what do I mean by this? So disulfiram will inhibit the other enzyme in this pathway, acetaldehyde dehydrogenase. And if you inhibit this, you can get a buildup of acetaldehyde in your blood. And acetaldehyde in your blood, if you have too much of this, it's going to feel very, very bad for you. You're going to get nauseous, you're going to have vomiting, facial flushing. And something to note is that some medications, like a few of our antibiotics, like metronidazole and Bactrim, can cause this disulfiram-like reaction. So anybody who's taking these, you usually advise them to limit or ideally avoid their alcohol intake to avoid this disulfiram-like reaction. So I just wanted to point those out, but let's move back on to the bulk of what I was talking about earlier, which is why would a significant alcohol intake result in fatty deposition in your liver? So what is happening here is that alcohol metabolism, as I alluded to, increases your NADH to NAD plus ratio. And it does that through both of these mechanisms here. In order to convert ethanol to acetaldehyde and to convert acetaldehyde to acetate, you need NAD plus to be converted to NADH. So notice through this process, we've already gained 2 NADH just with this one specific ethanol compound being metabolized. And so over time, all this extra NADH is going to increase your fatty acid synthesis. And that happens because if we look at the mechanism to convert our storage form of fat, all of our fatty acids, in order to convert this, to oxidize this into a usable energy source like acetyl-CoA, and I'm just showing you on the citric acid cycle here, you can see acetyl-CoA is highlighted in red now. This is an important compound to kind of get this process started, to use it as energy instead of having it stored as fatty acids. So in order to do that, you actually need to convert an NAD plus into an NADH. We just noticed though from our previous mechanism of converting ethanol to acetaldehyde to acetate that we're going to have a huge buildup of NADH. So if we have this big buildup of NADH, it's going to either decrease the pathway going from fatty acids to storage because we just don't have enough free NAD plus anymore. Or it could even, if you have so much NADH, it can reverse this reaction to where now you're having your acetyl-CoA stored as fatty acids. So you're getting increased fatty acid synthesis in this case, and you're getting decreased fatty acid oxidation or fatty acid breakdown. So people who have alcoholic fatty liver disease are typically asymptomatic. This doesn't really cause symptoms. On labs, though, you're going to find they might have mildly elevated liver function tests, and it could be your AST and ALT should be raised, but your AST to ALT ratio will be unique in that the AST will usually be greater than 2-to-1 ratio to ALT. And our mnemonic for that is our toast to alcohol, where you have your AST before the 2, and then you have your alcohol. So AST to 2-to-1 ratio. On histology, you're going to find a few things. You might see something called Mallory bodies, and you could also see macrovesicular fatty changes in the hepatocytes. So Mallory bodies are cytoplasmic inclusions due to intermediate filament damage in your hepatocytes. And if you look at the center of the screen here, you can see a Mallory body right here. It provides this twisted rope appearance, as you can see how it has this twisted rope. And I just remember when I hear Mallory, I think of a girl's name, so I think of the hair, Mallory's hair here that you can see inside of each of these cells. And you'll see Mallory bodies. It's not exclusive to alcoholic hepatitis specifically. All the alcohol liver diseases that we've talked about can result in these Mallory bodies. You may also see macrovesicular fatty changes in the hepatocytes. So what are these? So these are basically fat globules that are getting so large in your hepatocytes that it's kind of pushing everything else out of the way. So you have these large fat vesicles, and they can distort the nucleus. So I'm going to circle a few of the cells here. You can see many more. These are macrovesicular. You can see this massive fat globule here, and it's pushing the nucleus out of the way to where you can't even see the nucleus in the center of the cell anymore. You see macrovesicular changes. It's not exclusive to alcoholic liver disease. It's actually, you could see it in fatty liver disease, alcoholic liver disease, and some forms of viral hepatitis. And so my mnemonic for remembering macrovesicular changes is that you're going to see it in adult or macro. You know, when we become macro, like when we grow all the way up, then you might see these conditions. Later on, when I talk about microvesicular changes in things like Rye syndrome, which is a childhood disorder, I use that. When you have a microvesicular disorder, you're going to be micro or young, generally speaking. So now let's talk about alcoholic hepatitis, which is the subgroup of hepatitis that I wanted to discuss initially. So what happens in alcoholic hepatitis is that you have excessive alcohol consumption, and that leads to an acetaldehyde toxicity. So if we go back to our framework that we discussed earlier, if you have so much alcohol coming in, that's going to be converted to acetaldehyde and subsequently converted to acetate. But sometimes if you consume too much, you're going to overwhelm some of these enzymes, and they're not going to work as fast as they need to. So you're going to have not necessarily a blockage like that X indicates, but you're going to just have a buildup of the products before this reaction. So you're going to get a buildup of acetaldehyde. And we saw from people who take disulfiram that if you in any way either inhibit that acetaldehyde dehydrogenase or you build up your acetaldehyde in any way, it's going to cause some pretty significant symptoms sometimes. So in this case, you can get right upper quadrant pain and hepatomegaly. You can get a fever, as we'll see with most of the hepatitis with that itis. You can also get jaundice. Similar to the other alcoholic liver disease, you're going to have that classic AST to ALT ratio of greater than 2-to-1. And then on histology, you're going to have those same Mallory bodies and macrovesicular fatty changes that we just saw in alcoholic liver disease. And alcoholic cirrhosis is just basically the final form of each of these diseases. So it's going to be irreversible liver damage because of these chronic insults. This fibrosis and sclerosis is most noticeable in the centrilobular zone of the liver, which again shouldn't surprise you, given the propensity of that zone to have a lot of P450 enzymes and a lot of mitochondria. You might have regenerative nodules form due to that chronic liver injury. and you'll see regenerative nodules in a lot of forms of cirrhosis. And the histology is pretty much the same that we just saw. You'll see Mallory bodies, you'll see macrovesicular fatty changes, and you can see sclerosis and fibrosis. So we've talked about alcoholic hepatitis and the whole alcoholic liver disease subgroup there. Now we're going to do the same thing, except for this time we're going to talk about non-alcoholic steatohepatitis. So I'll start with all of the non-alcoholic liver diseases. So this is liver damage, as the name suggests, that develops without exposure to alcohol or other hepatic toxins. It's often related to metabolic syndrome, such as insulin resistance or obesity. So this can improve if you reverse any of these. So if you have weight loss or good dietary control, that can help with this condition. On laboratory findings, you're going to again have elevated LFTs, but this time because you're not having specific damage to the mitochondria, that might increase your AST ratio more than your ALT ratio. This time you're going to get more of your classic hepatitis picture where your ALT should raise more than your AST. And so there are three subtypes to non-alcoholic liver disease. There's non-alcoholic fatty liver disease, also known as NAFLD. You can get non-alcoholic steatohepatitis or NASH. And finally, the end form of each of these would be cirrhosis. So let's do the same thing we did and break down each of these subtypes, starting with non-alcoholic fatty liver disease. This is our initial stage of the disease, which can progress to the other two subtypes that I just discussed. And so how this one works is that you're going to have basically you're going to have free fatty acids infiltrate your liver, and that can happen in a few different ways. But I want to point out that in both of these mechanisms, insulin resistance appears to play a pretty significant role in causing this cascade. So just as a clarification, insulin, as we've discussed before, is more of our storage hormone. It can bring things into cells. So it can bring glucose into cells. It can bring free fatty acids into cells. And so if we have our bloodstream and we have a random cell here, if we have a bunch of glucose and free fatty acids in our bloodstream, the nice thing about insulin is that it can help us out there and help make the cell more receptive to these free compounds in our bloodstream and bring them into the cells. And this can decrease our blood glucose level. It could also make sure that our free fatty acids aren't getting into other places that they don't belong. So if we have insulin resistance, though, what's going to happen is that all those free fatty acids and all that glucose, instead of going into the cell that it's supposed to go to, it'll remain in our bloodstream. And if the adipocytes are intaking less free fatty acids, that means a lot more of those fatty acids can ultimately reach the liver and deposit into the liver. While this is going on, insulin resistance in and of itself can also upregulate liver lipogenesis. So it's actually, while you have this process going, you have additional free fatty acids that are just being produced by the liver spontaneously. So you kind of have a double-edged sword here where free fatty acids have two different mechanisms to deposit because of this insulin resistance. And as you can see, both of these processes lead to fat deposition in your hepatocytes. So the symptoms of this, just like the symptoms of alcoholic fatty liver disease were asymptomatic, this is generally asymptomatic. And the treatment is diet and weight loss. And now let's move on to non-alcoholic steatohepatitis. So this occurs when you have an influx of those free fatty acids, and sometimes those free fatty acids, if you have too many of them, they can cause oxidative damage to your hepatocytes. So again, if we have our free fatty acids that can't enter the cells, they're going to form in the liver, and those free fatty acids can occasionally cause an acute inflammation of your hepatocytes. And this can progress to liver cirrhosis if the damage is severe enough or chronic enough. And on histology, you're going to see something called ballooning degeneration, which I've highlighted here, which they kind of look like tissue paper almost, these cells. And then cirrhosis, I don't have a slide for cirrhosis specifically. I just wanted to reiterate again that cirrhosis, as with many of these diseases, is more of your final stage because of chronic inflammation and chronic damage to these livers. So this case would be chronic damage from those free fatty acid deposition in your liver. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.